Next panel. This one is our VC panel.
Yep.
Disrupting the establishment, what VCs are financing, but not only just we have VCs, we also have those from the provider space as well as the payer space. I don't see Kate.
I don't see Kate here yet.
Will be joining us. Kate Knutson, CEO of Optum, behavioral care. But I am going to hand this over to Archana for introductions because that's what she does.
Yes, that I get it jump started. So welcome everyone. So good to see some of you again and some new faces today. We look at VCs as, organizations that are watering the seed to build them up into a plant or a tree or of innovation and healthcare, especially in healthcare space. So we would love for you to do a brief introduction of yourself, your fund, what stage that you of funding that you do, and then also, since this is primary care, the quarterback, if you can share how you consume primary care. You could either share virtual care and nothing PHI, please. So no personal health information here, but just kind of share like how do you consume or look at primary care for yourself. So I'm going to go round my Zoom screen tiles and I see Dan first on my right side. Dan, welcome.
Hey, thanks for having me. I'm Dan Gallus. I'm a partner at Providence Ventures. And Providence Ventures is the venture capital arm of Providence Health System based out of the Seattle area. For those of you who don't know, Providence Health is about a $26 billion revenue health system, operates about 52 hospitals, 1,000 or so ambulatory clinics. So employs either directly or through our foundations in California, thousands of primary care physicians, and it's obviously a core part of the infrastructure that Providence has built over the 160 years it's been around. Our venture capital arm, we manage $300 million. We operate them like a traditional venture capital firm would. Our first fund was $150 million. We invested in 15 companies. We're investing out of our second fund right now, about halfway invested in that fund. We invest in digital health, healthcare services, and medical device and diagnostics companies. And the goal is pretty straightforward. We're looking at companies that, yes, we are entrusted with a lot of money from the system. It's all Providence money to generate venture and growth equity type returns, but also pretty prescriptively, actually, we look at only opportunities where we can see a connection coming together with our system. So we've made 26 investments to date. All of those companies work with Providence. It's not a mandate that is in place prior to when we invest, but we talk about getting really high visibility. And sometimes we hold our breath and think that our stakeholders are going to get there. And to date, that's happened, but we don't control those decisions. It's our stakeholders, but we try to create some connectivity with those folks and try to make our money greener, not only for the companies we're investing in and provide more value that way, but for the system itself. So that's our backdrop. I'm a very good primary care patient. Well, I don't know if I'm a good patient. I don't know if I'm a compliant patient, but I actually, I do have a primary care physician, a mix of seeing him in person and virtually, and have had different kind of health experiences over my years that have led to specialty care and made me a better primary care consumer. But, I think it's an amazing, I know some of the questions you're going to pose to us here, where things are going there. I think the world has already changed and it's going to continue to change with respect to what primary care physician and a quarterback means. I do think that will still exist. It's just going to be in a different form going forward. So thanks, look forward to the discussion.
Thank you, Dan. This was really impressive how, you eat your own dog food kind of in a way as you are bringing your investment into the Providence system. Parul, you're next on my tile set here. Can you introduce yourself and share how your investment strategy and then also size, and then how do you consume VCPs?
Yeah, sure. And thank you so much for having me. And it's great to meet everybody else on the panel. So I'm Parul Singh. I'm a partner at Initialized Capital. I'm based outside of Boston. Our fund does really early stage, so pre-seed and seed primarily. We're usually investing 1 to 5 million in early stage tech companies. We focus more on the software side and digital health rather than devices or pharma or biotech. And in the past decade, we have had the good fortune to be involved in companies like Ro, TruePill, Papa, Clipboard Health. We've made 18 healthcare investments to date, 9 of which are public and 9 which are still in stealth or like in the process of launching. And before that, I was at another fund called Founder Collective, where I was also involved in investments like PillPack, Flume Health, Human First, Omada Health, and then also more like consumer wearables like Levels and Whoop. So that's a little bit about my background, how I myself use primary care. I am still old school at this point. I have a primary care physician in person. I do tend to use a lot of test all the wearables and try a lot of them. And we supplement with different services for like various things like counseling or mental health or things like that. Or we've tried a number of different, we're definitely early adopters of a lot of this stuff, but our primary care physician is in person right now.
Excellent. Thank you. Thank you, Parul. Carl, you're next.
Hello, everyone. It's nice to see Parul and I are bringing up the Boston cohort here without the proper screen backgrounds. So apologies for that. I'm Carl Byers. I'm a partner at FPrime. I was on the founding team at Athena Health back in 1997. We started that company in a basement near Boston. I called the IRS to get the tax ID number. So I was definitely there the whole ride. I was CFO for 12 and a half years. We went public in 2007. Healthcare had not seen really the internet before we went public. So the healthcare investors were all confused when the tech investors piled in, and we doubled our value on the first day of trading. The company went private a few years ago for $5.5 billion in a fairly ugly shareholder activist manner, but it was to our benefit as investors because Jonathan Bush was liberated to start new companies. We've invested in 2 of them. Our fund family is a couple billion. We've recently broken out health, IT, and services as its own fund family. So we're just launching our second fund now, which is 200 million. For that, there's 2 of us who run that fund on a team of 5 professionals. Usually we're 3/4 of our dollars go to companies that have some early form of product market fit, meaningful revenues, but then we go early for more than 1/4 of the investments. We were the first money in, for example, at companies like Wellbe and Equip and a range of others. Notable investments include Devoted Health, another Boston proud group, my former colleagues from Athena, who recently raised $1 billion at a very hefty price and are doing amazing things. I'm an investor at Sondermind, at Embark, where Parul, you'll be glad to know, my main objective was to invest alongside Eric Paley, your former colleague, who's a good friend and a tremendous investor, and we're working on Embark together. And there are a range of others that we may bring up as time goes by. In terms of PCP, I think I have 3 PCPs at this point. I have my traditional one at Leahy. I was the first patient ever at Firefly, where we were an investor. So I'm patient number 1 there, although I think they kicked me off when they realized I'm not a company with a health plan. So, and then more recently, I signed up with a concierge like a week into it. And this is a physician who's the husband of an entrepreneur we backed, Sarah Milby. And he has a really cool concierge service that I'm just starting now. So hopefully I'll be healthier and fitter if we do a panel like this in 1 year as a result.
We should do a comeback panel, Bambi, and make sure that which one of these services really helped you. I see Sunny next. Welcome back, Sunny.
Sure. Thank you so much, Archana. It's a pleasure to be here. Hello, everyone. My name is Sunnykumar, and I'm a partner at GSR Adventures. We're an early stage tech-focused venture fund currently managing about $3 billion and deploying out of our 7th flagship fund, which is a $650 million combined vehicle. We look primarily to lead, seed, Series A and Series B stage financings. Our typical initial check size is anywhere between $3 and $15 million, primarily focusing on healthcare technology and really emphasis on the technology component, which we define as any deployment of emerging tech with the goal of delivering healthcare services far more efficiently and effectively than previously possible, and really looking for a transformative impact on the healthcare sector. So we don't look for ways to optimize things by 2% or 3%, but really get excited about how can we deliver healthcare 2x, 3x, 5x, in some cases 10x or even 100x more efficiently and effectively than previously possible. And happy to tell you more about that as we get into this panel later today. A little bit about me personally. I'm a physician by training, did my medical training out here at Stanford, have a background in artificial intelligence and informatics, did my MBA out at Stanford as well. And then prior to this was an entrepreneur working on a voice-based system for remote patient monitoring, ties into primary care as well, so we can touch on that. And then I've been at GSR overseeing our healthcare technology portfolio for the last 5 years. When it comes to primary care, I'm a bit of a hybrid consumer, so still do a lot of my primary care in person through a more traditional interface with kind of that one primary care doc. But increasingly, especially over the last 1.5 or 2 years, have been transitioning to more of a tech-based interface for primary care, getting a lot of my primary care through kind of the smartphone-based interface. So happy to touch on some of those points as well. Thrilled to be here.
Excellent, excellent. Thank you. Kylie, you're next. Welcome back.
Hi, everybody. Kylie Lee, I'm a partner at DCM based in San Francisco. DCM is a global venture capital firm, been around for 25 years, $4.5 billion under management. We're currently investing $900 million in our flagship fund 9. Been investing in healthcare for more than a decade across North America, China, and Japan, and across the value chain, primarily software, and from incubation to growth stage, with the sweet spot being seed and Series A. Some of the companies in our portfolio include Hims and Hers, Siren Care, Scanwell, Mendel, Stride Health, and a few others that are in stealth. And my background prior to DCM, I was also an entrepreneur. I founded a company called ChoicePass. It's an early work management platform that was acquired by Salesforce and became Salesforce's HR cloud, work.com. So personal background is more on the enterprise side, but I'm personally very passionate about healthcare and have been investing in healthcare for the past 7 years. In terms of how I consume primary care, I'm an early customer of One Medical. I've been with them for a very long time and have found their service to be excellent. I actually first interacted with them when I was an entrepreneur, and we had a partnership actually with them. And yeah, you know, started off initially with in person, and I like the tools that they use in terms of scheduling, same day appointments, things like that. But it really kind of moved to virtual, and so I kind of more recently leveraged kind of telemedicine, and then like others supplemented with other vertical solutions, you know, including Hims and such. Yeah.
Great, thank you. Thank you so much. Welcome. And Kate, since
Hi,
you
can you all
joined,
hear me?
yes, since you joined later, what we're doing is you're doing introduction, something about your fund, what stage do you invest, and then talking about your personal way that you consume primary care.
Great. Kate Hobbs Knutson. I'm a psychiatrist by background. My professional relation to primary care is through, I have built several integrated behavioral health and primary care programs at various stages of my career. I have worked for payers for about the last 10 years across Medicaid, Medicare, and commercial, and have built value-based payment models to help incentivize, well, first of all, pay for and fund, but then incentivize integrated care. Excited to be here with you all. Personally, for primary care, I do a lot of prevention on my own in terms of eating well and exercising and trying to sleep well. My actual involvement with primary care is more as I need it. Sorry, there's an airplane going over. I actually go as little as possible and really only go when I need it. But I do love my primary care provider, and I'm deeply grateful for the service.
Excellent. Thank you. Thank you. Back to you, Bambi. You're on mute.
All right. Yeah, so my primary care provider is Archana, actually. I don't think you guys know that. No, I do love her though, along with my other primary care provider. I want to apologize to the attendees because we have such an unimpressive group of speakers. I mean, collectively, they've all gone to either Harvard, Stanford, or Wharton. They basically funded all of these new innovative healthcare companies. I'm really honored that you guys are all here. So I want to start with a question. You all know what question I'm going to ask. We obviously we're talking about primary care and trying to understand from the traditional standpoint of a primary care, someone we have a relationship with. We did when you registered to the event, you took a survey and we asked you where you get your care from. Predominantly, people are getting it from a primary care physician. The second was retail and CVS clinics. So that was interesting to see. So I want to ask a question. We know we're changing, primary care is changing. So how is it going to change? Dan, you already alluded to it by saying that we're going to talk about this. You know it's going to change. So how do you think the primary care gateway will change, and how are you changing it?
Yeah, I think, I mean, we're seeing it today and still kind of in the early innings of having a few decades of entrenched kind of go to the office kind of care. And that's how primary care was delivered. We've really been changing, my old firm, we invested in Teladoc, and it was, a great company, but highly underutilized. And with COVID, when you look for the silver linings, everybody's been awakened to telehealth, and in particular clinicians. You look at Providence, and we've had a virtual program for 5-6 years, but we had a small cadre of physicians that staffed it, and they would, you kind of load balance it that way. Whereas COVID, overnight, every physician needed to learn and get enabled with respect to telehealth. So virtual is here. It makes sense. People now have a different, there's still a love-hate with it, I think, from a clinician perspective, but I think they understand it now better. So it's going to become integrated and part of practice for every kind of clinician, I think, on a go-forward basis. So that in itself is very different. I think the nature of the relationship, if you look forward 10 years, another great thing that's happening is we're actually treating patients are now consumers, right? So let's give choice. How do you want to get care? What is the preferred way? Now we can do it by modality. We can do it meeting telehealth in person or come to your home. We can also do it, I think people are more comfortable. Some folks will still want that one-on-one, and let me keep that same position. That's the one I want to interact with. I think there's also going to be team squad-based kind of care that just makes sense, where I personally, Dr. Wallace, my doctor, I don't care if it's Dr. Wallace, but I do kind of like that they've got all my information there. Now that I'm almost 50 years old and kind of moving to a point where I feel like longitudinal kind of viewpoint of my care is going to be a lot more important. I think for the younger, healthier generation, they could probably give a crap, right? In terms of that, that physician relationship. And that's going to vary by person, but I think that's the reality. So I think it's going to really change a lot what the nature of it is. But the core thing that I think there still will be that coach, that quarterback, or I guess, is value-based care, wherever kind of system you go into, whether it's providers that continue to push into it or payers who are going to drive it, you're still going to want the quarterback and have somebody be the chief of that care. And I think we're going to move even more towards that. The nature of that will be very different, I think, than how we've traditionally gotten primary care, though.
And I would like to add on the question that as we look next 10 years, is the primary care becoming more care navigation only? Or is it really, are we digging into enabling the comprehensiveness of of their practice? Because right now, as we see mergers and like, grand rounds merging with doctors on demand and just kind of packaging it up, are we, and still kind of the system is enabling that funnel into the specialist, or are we actually coming down and flipping the model upside down and having the primary care own it and get rewarded for the outcomes? And maybe then, because it's related, we could start from you, but also would love to kind of have the panel chime in on that answer.
Sure, and I'll get a provider, given that we're a provider system, we do have a health plan as well, but this biased view of it, or biased hope for it, because I do have a biased interest, I guess, in terms of Providence being successful in doing it. I think, primary care should do a lot more than what is in terms of, you should need specialists less often. From a utilization perspective, and primary care should be able, with the help of technology, to address and own a lot of the care issues that are being encountered on a traditional kind of daily basis. So I think their footprint will grow larger. I think the big question is, and I kind of lied as I think about it, I said I'm a good primary care. I cheat on my primary care all the time. I use doctor on demand if I'm out of state and I need it for my kid, and I'll go to Walgreens and get my flu shot. And so I'll do all these things. But ideally, and what Providence is trying to get to, is where we have a patient relationship, and it might be the doctor, but it might be Providence, that you push a button, and whatever it is, we know what you want immediately and try and be smart about it and route you to the right way and the right modality and so forth, so that we kind of become your care needs, kind of like if you're going to go shop on Amazon, you push the button, you go and look for Amazon. We want to be able to do that. Whether we can be successful in doing that, I think, is a question. But if we can be successful, primary care will do a heck of a lot more and be able to be smarter about accessing and referring to specialty care. But you do need to have that be at the push the button in order to manage that more effectively.
So Parul, from your perspective.
Well, I guess I'll push back a little in that I think that one of the challenges with, I definitely agree that it's really high quality. You talked about care coordination, and I do think that, a really high quality model of care does have primary care physicians as those care coordinators. But I think one of the challenges is that we're tens of thousands of physicians short just in those two specific practice areas of primary care and internal medicine. And so I think that it is desirable, but it's also, we've also seen that teams of providers are equally, if not more effective. Firefly in your portfolio, Carl, is kind of aligned around that model. And I do think that the big innovation of the last decade has been that patients can self-identify to solve their needs if there are niche areas. It's not so much necessarily like physician, especially for specific conditions, and then seeing those sort of full stack health solutions built around something which maybe is especially acute for a single patient, whether it's weight loss or cardiac rehab or migraines. That they're able to then treat self-select into being treated by the specialty providers. And so I don't know, I guess my answer is that I think it's still a really important role, but I see that role as being more distributed among other, not necessarily just falling on physicians, partially because of, I don't know if it's practical to do that.
Let me ask you, let me jump in there, Parul. How do you connect all of those conditions, and who's the quarterback for monitoring and integrating all those conditions? I mean, I guess you can be, but that seems like a lot of work for person two.
Yeah, that's true. And I do think that, we're seeing startups that are that are starting just to address specifically care coordination, that are not always, a physician reviewing everything, but it could be nurse practitioners, or like taking the burden of triage, coaching, referrals, and that being split up among a whole team. So I do think that it's, again, as I said, I see it as getting more distributed. Ideally, you do want a physician to be coordinating everything, but I just think that practically we haven't seen that occurring in the system as much as we would like, unless you are paying for more expensive concierge-like models. And so a lot of times the burden is on the patient, whether that's for better or for worse.
I could jump in and
Yeah.
Kate, as a warning, I'm going to hand it off to you with my answer. But, you know, a dirty secret a lot of people don't realize is your doctor, 95% of doctors do not know their patients. Like, we're used to this idea of like it's a relationship, but I teach at the Harvard Chan School and to a bunch of doctors every August. And I always say, raise your hand if you know your patients. And there's always one person who insists that she knows all of her patients, and everybody else is like, not a one. It's a nightmare when they come up to me at the PTA meeting because they have 2,000 patients. There's no way they can maintain a longitudinal memory of anyone but the frequent flyers, you know, like the chronic, you know, really interesting cases. So what I think it goes back to is the team concept. And then Dan mentioned data. You know, the large health systems hold on to data for their dear lives because they're oligopolies that justify jacking up the price on everything because you feel like, oh my God, if I go outside of the four walls of Mass General, no one's going to know anything about my healthcare. So I think as innovators, it's on us to make sure that that data flows. The patient owns that data, right? And if they have the data flowing in a secure way, in a compliant way, then you can have an actual team that includes different types of provider, including, Kate, mental health providers, because, you know, right now it's not like communicable diseases, COVID notwithstanding, that'll kill us, or accidents and injuries. It's we don't eat right. You know, we don't pay attention to our mental health. And so having a mental health component on a team has been shown, you know, proven to lower the total cost of care. And Kate, I think we met in the context of Quartet. I happen to wear my Quartet jacket. And you must have a perspective on this. Like, how do we make it so it's not like a hub and spoke, doctor knows best, when they can't actually remember their patients, but instead get a more integrated team going?
That's great. You know, when I think about integrated care for people with mental health and substance use disorder, I think about it really along a spectrum from mild mental health and substance use all the way to severe. For mild to moderate, first of all, the really important piece, the bulk of mental health conditions, like 75% of mental health and substance use conditions actually are mild to moderate. And so totally appropriate for treatment within primary care and or through, you know, virtual and sort of some of the programs even really outside of primary care as well. And so, and by just like you're saying, by integrating the behavioral health treatment in primary care, you're doing several things. First of all, improving access. So patients, when they are seeing their PCP, being able to access their behavioral health services right there is more convenient, oftentimes more acceptable, right? They choose their PCP for a reason. Maybe they like the person, it's close to home, close to work. They're more likely to receive the services if it's actually integrated with the rest of their healthcare. Less stigma. And then, like you said, especially for people, so it's been demonstrated well in Medicare for people with multiple chronic medical conditions that have co-occurring, you know, anxiety, depression. Integrated care has been shown to really reduce that total cost of care, really by improving not only the behavioral health condition, but also the physical health condition, so the management of the diabetes and cardiovascular disease as well. For people with more severe conditions, so severe mental illness, severe substance use disorder, that's really where we think more about what we call reverse integration. So where you might lead with a behavioral health provider, but put the primary care services there in that behavioral health home. And again, for that population, often their main touch points, their main trusted providers are behavioral health providers. So if we can, through virtual means, through actually in-person means, put primary care there in that behavioral health home, that's also been shown to improve access and likely improve outcomes as well.
I think I think those are sort of more people who are, well, maybe utilizing care more, although I know, Kate, you said that, you know, the majority of people who are struggling with mental health are, you know, sort of mild anxiety, so that's, you can actually engage with your primary care physician to with that condition. And unfortunately, there are all of these other services, mental health services that they're coordinating with to be able to address some of those conditions besides what they've typically done, which is typically 79% of the psychotropics are prescribed by the primary care physician, unfortunately, but thank goodness that's changing. Here's where I think I think everyone agrees, and we just had a panel with CEOs of primary care physicians. The panels have to drop. Well, this is a different panel. The patient panel has to drop, as Carl was mentioning. You know, they see 2,000 patients. I think everybody agrees the number of patients that a primary care physician has to drop, so they can have more care with people who actually need it more, the frequent flyers, or those with chronic conditions. The younger generation, though, and I think this is where we're seeing the D2C, and this is sort of touching on what Parul said, which is where, you know, you're going to go in for a certain condition, you know, hair loss, ED, you know, something like that. You go in and you might actually not see a particular physician, but you might actually have affinity with a brand. And that brand, actually, if you think about it, that can go with you for a long way. You know, I can be part of Hims and Hers or Row for, you know, when I'm 18 all the way till 35, right? And I could be 45, 50. And maybe that's what we're seeing, is that a change from people saying, okay, I'm going to have this PCP who doesn't know me, as Carl mentioned, and we're going to maybe associate and have a relationship with a brand. I don't know, and put that out there, but I think with the younger generation, that's a possibility.
I don't think you can discount the convenience factor for some of these opportunities. You know, I think, you know, Dan brought up a great point that, you know, these primary care physicians can act as amazing coordinators, and they should do more coordination. They really can take on more of that opportunity and responsibility. But the flip side of that is that by acting as a gatekeeper, they can actually add friction to the process. And if you're a relatively young, healthy person, you don't actually want more friction in this process. You know what you need when you're going to one of these service providers. And if there's somebody out there who says, I specialize in hair loss, ED, mental health, ADHD, whatever it is, and you can come to me, get your solution diagnosed, treated, et cetera, in a one-click type fashion, that seems like a very compelling value proposition to me. So if I know what I want, I know what I need, that's incredibly compelling. I think that's why you're seeing so much excitement around these types of opportunities. It doesn't mean that it's not complementary to primary care. It could exist alongside that. But I do think that you're going to see more and more of these types of opportunities exist alongside primary care and potentially be quite complementary, because folks are increasingly going to want their problem solved in a more direct fashion, as opposed to having to go through, gatekeeper type function, which is increasingly the way primary care seems to be functioning.
I think one of the things that Sunny is touching on, and Parul touched on this as well, is really the concept of accessibility. And with the direct-to-consumer folks, whether it's Hims or Hers, we're investors in a company called Weekend Health, which is focused on weight loss. Folks know what they want, and they want direct access to it, and they want folks that are very specialized in that. But I would group that actually still within primary care, because those are the areas that you typically would go to your PCP on, but a lot of people don't have one. And I think that while I believe that PCPs are underutilized, I actually think that at the same time, there aren't enough of them or they're not accessible enough to the general population. And so we have been thinking kind of about models where you can leverage others, right? Whether it's pharmacists, right? There's 38,000 pharmacy locations in the US that seem to have worked very well with the COVID vaccines. And the question is, like, how do you replicate an experience that meets that standard of care with others outside of PCPs and have them be partners? I think there's a huge opportunity there.
Yeah, and one of the things that we did in the opening mentioned that the integrated model in primary care tends to work a lot better and more efficient, exactly to your point, Kyle. It's kind of layering the right kind of resource. So this is kind of resource management in a way, because we are layering the right kind of resource whether it's a migraine solution or a pharmacy med-adherence solution, but ultimately there has to be one quarterback that allows for medical errors to be not happening, medication and interaction not happening, because this migraine medication now interacts with this depression medication. So those are things that do become really relevant from a patient perspective and patient journey perspective. So having, that's why we're focusing on them being the quarterback and maybe freeing them up to be the quarterback. And to Dan's point is that the information and fluidity of that data is an important superpower that they need to have in their hands with, to really, from Carl's perspective, to really know their patients. And that doesn't mean to know their patients longitudinally. They can have knowledge of the patient longitudinally if they have a smaller panel, but to really know their patient if they have a bigger panel and they're covering for another physician, that they truly know that person.
Yeah, to clarify what I was thinking, I think the primary care as quarterback, and think primary care doesn't have to be a physician, it could be a nurse practitioner,
Yeah.
there are extenders there. But I also think it's a subpopulation. I think it's the sick people, the rising risk population that's valuable. It's not a lot of what we're talking about here in terms of not creating friction to go get services is going to be dictated by the plan you sign up for and what you want to pay out of pocket. Because a lot of these, if you want that freedom, plans are going to start making you pay for that, for those kinds of things like that. Otherwise, they're going to want they want to target the people who are really the high cost folks. That's where they want the quarterbacking. And I think it makes sense. And it's a good thing. And it really, to your point, Carl, it's data. And if we can make EMRs extensible and so forth, that physician who, I like to think Dr. Wallace knows me. I don't know that he does. But he at least can reference the chart and see what he did last time, which is helpful, I think. That's another discussion. And I hear you on the providers. Do we want to let that be free? We can't even make it free amongst our own physicians. We struggle with that from instance to instance of Epic. So there's a lot of issues there. But I do think primary care and the value of it as a quarterback, it really should be population driven. And then it's really plan design for if people want that flexibility and freedom to pick and choose, you're gonna have to pay for it because that's a good luxury to be able to do that. And if you want it, then I think you're gonna have to pay for it.
Yeah.
Which I mind if I share my screen here and we'll still be able to see each other, but I wanted to share this screen because I wanted to, rather than be abstract, maybe we can all be a little bit more specific about, we're all talking about integration, and sorry if you have a company that's not on here or if I mislabeled your company, but just for ourselves and also for the guests, if you think about where you want to be in terms of, look, we can't have an integrated model. We have a vision of where we want to be, but we got to start somewhere. And where is the best gateway for investors to look? And so I'd love to talk about that if we can. I don't know who wants to start.
I was thinking maybe we can start from Kate, is because being a venture inside a payer that is really carving out what the member or the patient experience looks like. I would love to hear, how are you using the levers of, using the power of like payment to make this change happen from Optum perspective. And would love to hear what is the strategy around investment and adoption of these newer models in primary care?
So I'm best able to speak about this from a behavioral health perspective. In terms of, and so ultimately, if we can move more towards, as the team has been talking about, population-based models, so where you've got a population of people, providers are accountable for that population. Ideally, we're moving towards more prospective payments for those providers that are at risk based on total health and costs. And just like everyone has been saying, providers can work with payers to risk stratify the population, and totally agree with the comments that were being said earlier. The real opportunity with the primary care provider as the quarterback around case management, around team-based care that includes behavioral health, is for that sort of sicker population that may have multiple chronic conditions. That's really where that coordination comes in, and is so important. At the same time, there's a large majority of people who don't have multiple chronic conditions, right? And that would benefit and want these more sort of accessible approaches. And so that is where, we and many others are looking to invest and find alternative ways to pay for those approaches. So, through different payment models, through things like, store, like virtual stores almost, where people can come and self-identify, as was said earlier, and get the services, sort of direct themselves to the services that they want.
And do you invest in those newer models in which there is panel management, and can you share, like, what is the strategy? Do you build incentives around your payment model?
Yeah, so again, for behavioral health, and again, that's where physical health is integrated. So the ideal is there's a provider or provider group that is responsible for a population, and then their outcomes that they're at risk for are both in terms of physical health outcomes, so showing that diabetes gets better right alongside the depression, anxiety, that costs are at least maintained, if not improved across the total cost of care, and then that people are happy with the service and providers are happy, really sort of along the quadruple lane. But that's the basic gist of it, is population prospective payments that are at risk based on those health outcomes across physical and behavioral health.
So
I
we
wanted to,
yeah, go ahead.
did you? Well, I didn't want to keep up this slide for that long, so I wanted to address the slide. I just thought it was an interesting way to just take a look to see where the investors were thinking that was the best place to make a bet. Maybe that's something that you have a portfolio company in each one of those buckets, and certainly I've missed some, like there's all that world, women, just specifically women's health is one, and then wearables I've missed, but just as a starting point, if you think about where are the areas or the boxes that would be, where you want to put a stake in the ground and then build from there, what looks interesting?
My two cents is that I think there are interesting companies in all of these buckets. I think what you've done is, on the right side, you have sort of fulfillment. And so, for example, I think it was Sunny pointing out, like, if you have a particular condition, you just want to get it taken care of, that's one thing. And so, like, a row, hims and hers are right there for that. Well, there's another, the left seems to be, inputs or navigation, but it's that center column where you really have the beginnings of what we like to call a health fiduciary, who is someone who's responsible for keeping you healthy and has a budget. And that kind of gets a little bit of what Kate was saying about population health. But I would think of Kaiser as the ultimate health fiduciary. Devoted's trying to do the same thing. Medicare will soon be 5% of GDP. So think about that for a second. 5% of the entire economy of the United States will be Medicare by 2030. So those populations do need someone to look at all the chronic conditions and manage care and go at risk, like Kate was saying. I think could also highlight one other thing, which is the health fiduciary, the quarterback, as you've put it, or maybe that's too gendered. Maybe we can call that person the Wonder Woman. The Wonder Woman can put it all together for the patient, right? But then there's specific things that require persistent, ongoing engagement, such as, for example, an eating disorder. Like, we're an investor equipped for that. Verta is focused on, actually reversing type 2 diabetes. There are certain things where the primary care provider or service is not going to be ready to handle that in a specialized way. Substance use disorder would be another one. And that's where, if they can hit an easy button and know their patient is being cared for, and that they will hear back from that service, how's it going? Are we making progress? Do we need to suggest titrating certain medications that the patient is on. Then you start imagining, I think of it like a cube. The front slice is the health fiduciary. They're at risk for the total cost. They're responsible for the health of the patient. But then you have these specialized kind of slices behind it. And then data and payment and risk sharing kind of will tie those entities together. And I think as we get going with more entities, whether those are Fireflies or One Medicals or whoever, who really do provide that comprehensive service, then they will work with everybody else to kind of reshape the way the industry actually works. That's my hope anyway.
Yeah, and Carl, you're absolutely right. So what is happening, we're almost building a layer between the quarterback, which is becoming very tech enabled, I would say, or primary care physician, which is a horizontal service, your first door, and creating verticals, which is also virtual, before the head specialist. So you got the Vator for diabetes, you got your weight loss for MATA, we got, diabetes, Livongo and others, I mean, more kind of on an employer side. We got PTSD and panic disorders from FreeSpira. Those will become referral pathways for primary care physicians. And then hopefully, the payers will incentivize using more of these tools and less of the specialist, because these organizations are really driving outcomes and cost and aligning better with that and decreasing overall cost from the healthcare system. One of the companies, AliveCor, I'm chief clinical officer there, that's in cardiovascular, and cardiovascular is the most expensive. And every 36 seconds, somebody dies in the US from heart disease, and we saw it performing worse during pandemic. That's why I chose to go from HP into product, because we really need to do something about cardiovascular in a more systematic way. We don't have a solution out there that does a good job with cardiovascular. So these are the verticals. These are the virtual specialists that are being formed, and that would be in the hands of the primary care physicians who are also going hybrid in a way.
So I want to ask Kyle and maybe Sunny, we talked a lot about, there's a lot of money, there's $20 billion in investments going in to digital health in just the first 9 months of this year. So record levels. We're seeing consolidation because these valuations are not sustainable. What areas do you think we're seeing over investment? And
overcrowding too.
Overcrowding.
Yes.
This may or may not be a popular opinion. I suspect it may not be, but I think there are way too many mental. A lot of them have gotten funded at very high valuations, just given the impact of COVID, and I just don't think that a lot of them will have sustainable businesses once things start to normalize a bit. I think that the market itself is huge, but it does not justify just the number of companies that have gotten funded.
Yeah, I would agree with Kyle too, that the markets that we're talking about here are absolutely massive, hundreds of billions of dollars of opportunity. And if you're honest, like, yes, it's possible that all of these companies could potentially be successful just because of how big the market is, but realistically, that's not likely how the trajectory of the sector is going to develop. The one thing that I would look at when I'm evaluating any of these companies, whether that be mental health or telemedicine, which I do think are relatively crowded, just given how much money is going into these spaces, is what's the differentiated level of impact that you can create? And that's kind of the additional access that I would add to this market map here. I think all of these, to add to Carl, all of these sectors were super interesting, huge potential to create impact. But the challenge here is that, trying to create and scale a company in any of these spaces is really hard. And when you look at them, yes, if you take any of the diabetes companies, for an example, if you can generate cost savings of 5% or outcomes improvement of 10%, nobody would doubt that that's a meaningful impact. But when you sell a solution like that, that's where the challenge happens, because when you're trying to sell a solution and that's the level of impact you're creating, it becomes very hard to differentiate yourself and really try and create a compelling narrative there. What we get really excited by is how can you create a much bigger story? How can you create a savings of 50%, 60%, 80%, maybe even 90%? If you're talking about that level, that's where you're really going to move the needle. That's where you're going to change things at a societal level. And it doesn't matter which of these categories you're in. If you're talking about that level of magnitude, that's where you're going to be able to still differentiate yourself, regardless of how crowded that sector is today.
I'm going to turn this off unless anybody still wants it on.
We could also ask perspective from Parul, and then also Dan, which areas do you think are overinvested and overcrowded? And they could be different. And then also Carl, you have, and Kate.
Yeah, I think it's funny because I still think we're in the early innings. When you look long term, I guess anytime if you look long enough, you're still in the early innings. But I think some spaces have been carved out and companies have some very big footprints already. When you look at kind of the telemedicine space in terms of who's called on the payers and employers and so forth, and gotten a lot of traction with Teladoc and MD Live and folks like that. I think that's, there's niches there, and they've got big market cap companies. So you can build something for, youth population, so forth. So you're seeing some interesting kind of niche plays that, Teladoc or somebody could be an acquirer of. So there's still venture opportunity, but I think those spaces are probably, played out a little bit more in terms of who's going to be the winner, or who are going to be the bigger winners there. I think the bigger issue that I see, and I think all of us could kind of acknowledge that when you look at that financing chart, I remember when you put the slides up before, it just blows you away. I mean, if you'd asked me pre-COVID, looking at the bar chart, I'd be like, wow, it's pretty frothy. And then all of a sudden you look at what happened the last 2 years, there's going to be some great companies built, which is really exciting stuff that I haven't seen in my career. But it just doesn't sustain. It's impossible to get a return on all that capital. So there's going to be some big blowups and losses, but there's going to be some great companies being built. So it's great for society and consumers, and just the returns will be interesting, and on some really big ones and some tough ones, really tough ones.
Thank you, Parul.
I agree with the consensus on the panel. I mean, I think that it's, not to be understated that the impact that patients have embraced telehealth, but undifferentiated telehealth, like when there's no diagnostic or data layer, it's hard to see how. Well, I think that some of the existing solutions will be able to take care of those needs. That said, I do think that we're seeing, at least via pitches, that it still feels like we're in this Cambrian moment of D2C, ever more niche offerings, which on the one hand, I'm excited about for the patient choice aspect of that. But on the other hand, also think that it's going to be harder and harder for those companies to stand out.
And Carl?
I guess we're all paid to have a crystal ball about these things. The valuations continue to rise, everywhere. No one's got the memo about the, risk-free rate of return going up. But I guess I think at the end of the day, there's so much money spent on administration in healthcare, and that's not even touching care that doesn't need to happen, or the fact that it's really this market share game between payers and providers. And so in most markets, there's a large health system that can literally charge double for everything they do because they have primates in the basement, and I think it's a digital health at a broader level that will start helping people navigate and take control. I think the doctors and the services that employ doctors on your behalf will be the ones helping you navigate so that you can get the care you need in an efficient way without going into these very expensive, very bureaucratic institutions that, yes, they can save your life when you have a rare item, rare disease, or rare condition, but you don't need them for a lot of the basics. That's the reorganization that's going to happen over a long period of time. And so I think that the venture opportunity is tremendous to move care into the home, to move care into modern UX platforms. But of course, it's healthcare, it's life and death. And so we have to make sure it's done responsibly. and well, so we'll take some time. So maybe that's a non-answer, but I think it's I kind of all of the above, but only if done well. Many of those companies will get consumed by the other companies. Some will fail. I mean, a lot of the SPACs are losing hundreds of millions overnight. Like Talkspace yesterday lost 36%. So, I think we're going to see a lot of that kind of Darwinian, to go with the Cambrian, the Darwinian behavior, but there will be a transformation over time.
That's great. And Kate, what are you seeing from your lens? Is overcrowded and or overinvested?
Yeah, I agree. There is a lot of investment right now in mental health and substance use disorder. Honestly, I think it's from a clinician and a person perspective, it's fantastic. The access to care, as you all know, and the recognition of mental health and substance use disorders has been really dismal for decades. And the fact that there's so many companies out there, and people are able to access services easier now. That's really fantastic. I do agree that the sort of point solutions are a challenge. And especially if you're a payer, for example, trying to deliver comprehensive services, having so many point solutions is really hard to sort of pull together into some sort of comprehensive offering. And then so having a way to pull together the point solutions is an important next step. The other thing is that there are still conditions out there that where we're really lacking good scalable options. So serious mental illness is one, for example. So severe depression, schizophrenia, bipolar disorder. That's one where there's not a lot of good scalable options out there yet. So I think there's still, even though yes, it's all under the umbrella of behavioral health, I think there's still some areas of behavioral health that are ripe for further development.
All right, Archana, I think we're almost 10 minutes over for the panel, but we also started 10 minutes late. So maybe we'll wrap it up by asking this question of everyone. So you heard our last panel where Dr. Robert Pearl talked about how the economics have to change, and then that'll change culture, that'll change incentives, that'll change just how we consume healthcare. So I want to ask you, what excites you? It could be a company, it could be a business model, it could be just an approach. I'll give you an example. You guys talked about mental health and how that's just bombarded with so many companies, but I love Better Up because I think it's a totally different approach to healthcare, because it's not looking at clinical, it's looking at flourishing. So it's going in a totally different direction. So there's no uniqueness about its business model, but what excites you, whether it's a new business model or just a new approach to healthcare? So let's go with Sunny. We'll start with you.
Yeah.
Sure. So the vision that I'm most excited by is the opportunity to combine technology with people. So not getting rid of doctors, but combining technology with doctors and other providers to reduce the cost of care by a massive amount, by 10x or even 100x. And the goal there is to just change the fundamental business model of healthcare delivery of primary care. The vision that I have, and we have the opportunity to work with companies doing this, to get to a mode in where you can actually deliver primary care for free to patients, so that going to see your doctor literally costs zero, not with insurance, not with anything, literally costs zero to the patients. And then finding other ways to monetize those opportunities. We think that would be a truly disruptive change to how healthcare is delivered in the US, maybe throughout the world, and then creates entirely new ways to interact with your providers.
Nothing is for free. Are you talking about government providing that free?
No,
literally
but
for free.
I like that. I like that. The 30% inefficiency should be paying for the PCP to remove that 30% inefficiency. And then the salary is, it's capitated, which Dr. Pearl talked about. It's like your salary has nothing to do with how much headcount you're seeing. Your salary has to do with how much cost you're saving and how much care you're improving. So that's it. So
absolutely.
Right. Yeah. Parul, what excites you? The business model or technology or just a vision?
Well, so I think we've talked about precision care for like a decade and a half, maybe 2 decades. And what excites me is finally starting to see companies that are actually doing it. I mean, I think all of us kind of benefited, whether, whether it's targeted vaccines or therapeutics, or what I'm seeing are direct to consumer companies that might take, say, a genetic test and prescribe based on that. And I think we're finally at this point where all of these, advances over the last decade and a half, like whether it's cloud-based care or CRISPR, like we're actually able to process that data and use it. I think it's taken us a long time of all of these pieces to be able to get to that point. And I think that's what I'm really excited about.
Awesome. Thank you.
What about you, Carl?
It's all about the blockchain. No, I'm kidding. Longtime crypto investor. I'm not throwing shade. To be serious, I think really we need software developers to embrace the sector. We have all the digital investment happening now. We're investors at Zeus, which is Jonathan Bush's new company, which is essentially let them be the back end, don't reinvent the wheel and keep making a new, HIPAA compliant architecture, just focus on the front end. So I think if developers can embrace something like Zeus, the way developers embraced iOS, let's say, or GitHub, then we're going to have this, you can have as niche of an offering as you want, but the data is going to be integrated on the back end. Things are going to get paid for, fintech will come to the rescue. I think we're going to get it all figured out. And I think it's going to require a lot of software development done in conjunction with clinicians, and probably less and less administrators.
How about you, Kate? What excites you? Any new interesting business models down the pipeline, or new technologies, new opportunities?
I'm excited. Well, again, I'm excited about just the major advancement in the field that we've gotten through these technological advances. We've had this major problem where you've got treatments that work, but they don't get to people. That's our major opportunity here. I'm excited about remote person monitoring in mental health. So there's a lot that we can do through biofeedback, through remote monitoring, passive monitoring, that will help not only the clinical practice, but also will help us advance value-based payment, and also early crisis intervention, those kinds of things. So I'm excited about that going forward. And then again, excited about just our opportunity to change how we pay for care, and really be able to align all of these, new technologies and providers with the right outcomes.
And then Dan.
Yeah, I guess I play off that, I think, but in a very low tech way. You're thinking about remote patient monitoring. I think, and maybe it's jealousy because we don't have a company in this space yet. It's really practicing the top of your license, looking at the low end license. So folks who are lower credentialed clinicians, think home care, in the home, people who are in front of the people who are the sickest and the most in need or at risk, rising risk, taking note, figuring out ways that we're actually connecting that so that the payers and the providers who otherwise should, could help in advance when people are having issues, and then social determinants factors into that. But it's leveraging lower credentialed and non-credentialed folks in a healthcare capacity that's really can do a ton from a cost-effective perspective. So I'm happy to see some of the companies that, and in Medicare Advantage and other plans that are opening up the coverage for some of these types of services, which I think will drive further investment and utilization in a smarter way of those kinds of assets and people.
And Kyle.
I echo a lot of what has already been said. I would just add with the integrated care models, we're really excited about the greater use of data for specific use cases. One in particular around just better diagnostics. I think that will help to lower the cost of care overall, because so much of it is like wasted again, not on having the kind of quarterback to really help assess that, and then leveraging kind of AI and data to be able to augment the PCP's assessment or specialist's assessment on particular conditions.
So if I can sum it up, we're excited about data so we can diagnose better. We could do more remote monitoring for early crisis intervention. We can get more precise using genetic tests to do more precision care, and we can rally all those software engineers and take them away from social media and get them excited about looking into healthcare. And then we'll create this delivery system where we're leveraging all of these assistants or workers who can support
remote patient monitoring tools. Yes. Yeah.
Or just people, as Dan mentioned,
home-
who could support
yes.
the physician
Mhm.
who will ultimately treat patients for free.
Yes.
I would say. So
Exactly.
anyway, this is great. I appreciate everyone's time. We have to move on to the next panel, but the next panel will consist of a number of chief medical officers, and we're going to be talking a lot about the sort of how doctors are engaging, are they being satisfied? Are they making enough money? How are patients, how are we changing the delivery to patient? Are they now going to be more like consumers? And we're going to talk about this from the standpoint of a physician. And there's a couple of questions here in the Q&A asking about sort of more physician questions. So we're going to hold those off until the next panel. So we want to thank everyone for joining us. Thank you so much. We had a rock star panel, and we'll have this on video, but thank you for taking the time.
Thank you. Thank you so much. Really appreciate it.
Thanks
Great
a lot.
conversation.
Thank you. I am going to